Okay, good morning, everybody. I think we're going to start on time as we have 4 fellows presenting today. We have Drs. Hubbard, Kelly, Hendrickson, and Golden, each presenting their fellow research projects. We're going to start off with Dr. Hubbard this morning to talk to us about the PASS score in the hand surgery population.
All right, thanks for the introduction, Dr. Tischer. So my name is James Hubbard, for those of you I haven't met. I'm one of the hand fellows for this year, and I'll be presenting our work on establishing the patient acceptable symptom state for the QuickDASH and PROMIS upper extremity computer adaptive test in a hand surgery post-op population. So the ability to measure both surgical and non-surgical outcomes is fundamental to our ability to critically evaluate the various treatment modalities we offer our patients. There are many ways in which we report outcomes, including radiographic measurements and clinical evaluation, which are both dissociated from the patient's lived experience. Recently, a greater emphasis has been placed on patient-reported outcomes instruments, which attempt to capture the patient's subjective perceived outcome. One of the patient-reported outcomes instruments that we collect regularly is the QuickDASH. This is a shortened version of the disabilities of the arm, shoulder, and hand questionnaire, which asks the patient 11 questions, 8 relating to upper extremity function and 3 relating to upper extremity symptoms. It's scored from 0, a state of no disability, to 100, a state of most severe disability. Additionally, we collect the PROMIS upper extremity computer adaptive test, which is a subset of the physical function computer adaptive test, relating only to upper extremity function. Scores are reported as a T-score, where a score of 50 represents the population mean, and every 10 points above or below 50 represents a standard deviation from the population mean. The benefits of these instruments include that they allow for assessment of the patient's perceived function, symptoms, or both as a continuous variable, which makes it easy to stratify outcomes and perform statistical tests. The problem with patient-reported outcomes instruments, however, is that they're reported as a vaguely meaningful number. For instance, we know that a QuickDASH score of 70 is supposed to represent a patient with a greater degree of disability than a patient with a QuickDASH score of 50. But what does this actually mean? The first patient would never describe their outcome in terms of their QuickDASH score. They would describe their outcome in terms of what they can or can't do, and other nebulous human concepts like satisfaction or dissatisfaction. Additionally, because these instruments report outcomes as a continuous variable and are easy to use for statistical analyses, there's been a proliferation of studies demonstrating treatment effects in terms of patient-reported outcome scores that result in statistically significant differences between groups, but leave us wondering, do the differences in scores represent anything clinically meaningful, and what constitutes a good outcome versus a poor outcome? Further, as we emphasize higher quality studies in larger populations, the statistical power to detect very small differences in outcome scores increases. We thus run the risk of correctly declaring our findings statistically significant when they are in fact clinically meaningless. Given these challenges, many authors, including several at our own institution, have begun to work on understanding how to interpret these instruments in a clinically meaningful way. Several concepts have been put forward to this end. The first to be introduced was the minimal clinically important difference, or MCID. This is the smallest difference in scores that represents a clinically detectable difference in outcome. The substantial clinical benefit, or SCB, is the difference in scores that represents a substantial clinical improvement. Where the MCID asks, does this difference mean anything at all? The SCB asks, does this difference indicate that one group has done substantially better than the other? Finally, the patient acceptable symptom state, or PASS, represents a score threshold beyond which a patient considers their symptoms or function acceptable. Where the MCID and SCB provide metrics for change between groups, the PASS provides a target score beyond which a patient may be considered well. Our group has previously published on the MCID for these instruments and has a publication under review for the SCB, but the patient acceptable symptom state has not been established for the QuickDASH or PROMIS UE-CAT in a non-shoulder, hand and upper extremity population, leaving a void in our understanding of how to interpret these instruments. So the purpose of our study was to establish the patient acceptable symptom state for the QuickDASH and PROMIS UE-CAT in a non-shoulder, hand, and upper extremity population. We recruited all adult patients treated surgically by one of 4 fellowship-trained orthopedic hand surgeons between February 2019 and December 2019. On their 1-year post-op anniversary, they were emailed a link to complete the QuickDASH and PROMIS UE-CAT, as well as a symptom-specific anchor question and a function-specific anchor question designed to determine whether or not the patient deemed their symptom or function state acceptable. Patients were included if they had responded to one of either the PROMIS UE-CAT or the QuickDASH, and one of either the symptom or function specific anchor questions. Additionally, we collected demographic data including age, gender, race and ethnicity, treating surgeon, marital status, alcohol use, smoking status, ASA class, area deprivation index as a national percentile, and whether or not the patient was undergoing surgery secondary to a traumatic injury. The symptom-specific anchor asked, if you had to spend the rest of your life with the hand and upper extremity disability symptoms you have now, how would you feel about it? The function-specific anchor asked, if you had to spend the rest of your life with the hand and upper extremity function you have now, how would you feel about it? Responses to both anchor questions were scored on a 5-point Likert scale. Patients who responded that they were either very satisfied or somewhat satisfied were deemed to be in a patient-acceptable symptom state. Patients who responded that they were neither satisfied nor dissatisfied, somewhat dissatisfied, or very dissatisfied were deemed not to be in a patient-acceptable symptom state. Demographic statistics were compared between past positive and past negative groups for each of the anchor questions. Several methods have been employed in the literature to determine past threshold values, and we use these three to provide several different values for each estimate. The mean score method is simply the mean patient-reported outcome score for all past positive patients. The 75th percentile method is the upper quartile patient-reported outcome score for all past positive patients. And the Uden index is the point on a receiver operating curve that maximizes sensitivity and specificity in categorizing patients as past positive and past negative. And it represents the point on the ROC curve that is furthest away from the line of unity. 222 patients met inclusion criteria. All responded to both the QuickDASH and PROMIS UECAT, as well as both anchors. The mean age was 52 with a standard deviation of 18, and 52% of respondents were female. The most common surgeries in the cohort were carpal tunnel release, LRTI, and distal radius ORIF in that order. In an effort to make an already horribly busy slide less busy, I've included only the demographic categories that demonstrated significant differences between past positive and past negative groups. Consistent across both the symptom anchor and function anchor, past positive patients were significantly more likely to identify as not Hispanic or Latino, to identify as white or Caucasian, to have never smoked, to live in a neighborhood with a lower area deprivation index, and interestingly, to be undergoing surgery following a traumatic injury. The mean PROMIS UECAT score for past positive patients was 51, and this was significantly greater than the mean score for past negative patients. The mean QuickDASH score for past positive patients was 9, and this was significantly less than the mean score for past negative patients. Using the mean score for past positive patients, the pass threshold for the QuickDASH across both anchors ranges from less than 9.4 to 9.5, and the pass threshold for the UECAT is greater than 50.7. Using the 75th percentile method, the pass threshold for the QuickDASH across both anchors is the maximum outcome score of 0. And while theoretically the UECAT ranges from 0 to 100, 61 has been demonstrated to be the maximum score in practice, which is the pass threshold for the UECAT as determined by this method. And then finally, using the Uden index method to estimate a range for pass based on the two different anchor questions, we got a range of less than 15.9 to 20.5 for the QuickDASH and greater than 38.1 to 46.2 for the UECAT. These are the ROC curves for the QuickDASH and UECAT based on the symptom anchor. And these are the ROC curves for the QuickDASH and UECAT based on the function anchor. We see that all curves fit nicely into the upper left-hand corner of the graph, indicating that the QuickDASH and UECAT function as good diagnostic tests for predicting whether or not a patient is in an acceptable symptom state. While the study was not designed or powered to determine the effect of various demographic factors on the threshold for pass, it is at least suggestive of the fact that socioeconomic factors may play a role in determining the patient acceptable symptom state. Similarly, it's suggestive of the fact that patients undergoing surgery for traumatic injuries may have lower expectations for acceptable symptoms and function than patients undergoing elective surgery. We determined pass thresholds by using 3 commonly published methods. All 3 methods provided very different estimates for the pass threshold, and seeing all results juxtaposed allows for critical appraisal of the different methods. The mean pass positive method is a crude estimate that seems arbitrary at face value and by definition fails to correctly classify a large portion of pass positive patients. Half of all pass positive patients in a normally distributed population would by definition be predicted to be pass negative. The 75th percentile method originated with this graph presented here, published by Tubak et al. In 2005. For their distribution of data, the 75th percentile pass positive patients appears to maximize true positives and minimize false negatives. That said, unless your data distribution roughly approximates this, this may be a wildly inaccurate method. In our case, we had a large ceiling effect in our data, and this method resulted in pass thresholds at the maximum score for both the QuickDASH and the UECAT. This should give other authors pause in adopting this as a default methodology for determining a pass threshold. The Uden index provided pass threshold estimates for the QuickDASH of less than 15.9 to 20.5, and the UECAT of greater than 38.1 to 46.2. The pass threshold is essentially a diagnostic test, and the Uden index method optimizes the sensitivity and specificity of the pass threshold for predicting a patient acceptable symptom state. Thus, the statistical method makes sense given the goal of the study. Further, it provides an objective measure of test performance in the AUC value, and for all pass thresholds in our study, the AUC was greater than 0.8, consistent with good test performance. Our study did have several limitations. First, we collected responses to the anchor questions on a 5-point Likert scale. Ideally, this would be assessed using a binary instrument. Either the patient is or is not in an acceptable symptom state. That said, there is precedent in the literature for how we classified patients as pass positive and pass negative on a 5-point Likert scale. Second, there's no gold standard anchor question for determining the patient acceptable symptom state. Little is known about the psychometric properties of these single item global assessments of symptoms and function. Establishing the validity and reliability of these instruments often hinges on an external anchor, which raises the question, is it just anchors all the way down? In order to mitigate this weakness, we established estimates for the pass threshold based on 2 differing anchor questions. Each produced pass thresholds which differed by more than or nearly more than previously established MCID values for these instruments, underpinning the importance of use of language in formulating these single item instruments. Third, the cohort consists exclusively of patients who are 1 year post-op. It's possible that some of the patients within the cohort are still improving after surgery. And for those who have maximized their outcome score, they may still be learning to cope with their final function or symptoms. It's possible that the pass threshold may change with time given this. Fourth, we lack baseline patient reported outcome scores and anchor responses. It's likely that the patient's baseline function and symptoms affect their ability to achieve an acceptable symptom state. Further, this might be difficult or impossible to obtain for patients undergoing surgery in the trauma setting due to the nature of their presentation. Finally, our patient population is fairly homogeneous. In just a few months, I'll be trading delicate arch for the gateway arch, and I know our population does not reflect the demographics of St. Louis, so it's hard to say if our results would be applicable to the population I'll be seeing in my new practice. In terms of future directions, the study raises many questions, including, what are the effects of socioeconomic factors on the patient acceptable symptom state? Do these change with a more diverse patient population? And are any of these factors modifiable? Do trauma patients actually have a higher tolerance for symptoms and limited function than patients undergoing elective surgery? And within the elective surgical world, are there more granular differences between differing elective procedures? Does time from surgery have an effect on pass? And is this a function of continued improvement in function and symptoms, or is this a function of patients coping with the function and symptoms that they have? Does baseline patient reported outcome score affect a patient's ability to achieve a patient acceptable symptom state? And finally, can we assess the validity and reliability of our anchor questions, since our results are reliant on the assumption that they themselves are accurate, valid, and reliable measures of a patient's function and symptoms? So in conclusion, a QuickDASH score of 15.9 to 20.5 or less, or a PROMIS UECAT score of 38.1 to 46.2 or greater, indicates an acceptable symptom state in our postoperative hand surgery cohort. These values may be useful for study design or when interpreting outcomes in the literature, both prospectively and retroactively, where patient satisfaction is not reported alongside scores for these instruments. Secondarily, we would caution other authors that the commonly reported 75th percentile method for determining the pass threshold may only be valid for a specific distribution of outcome scores. And in our particular case, where there was a large ceiling effect in our data, it provided threshold values that represented perfect scores on the QuickDASH and UECAT. So with that, thank you for your attention, and I'll open the floor to questions.
Thank you, James. Any comments or questions from the audience here?
James, I thought that was an excellent presentation, an excellent study. It really underscores the complexity of trying to figure out how to use PROs and how to interpret them. And many of us struggle with that regularly. So those of us trying to use it during the care of patients are trying to figure out where this individual patient score fits into the greater whole. And you've sort of really underscored the challenge we face in trying to figure that out by way of understanding what's acceptable. And I would submit that acceptable to some patients is unacceptable to others, which sort of adds to the complexity. The same score might be acceptable to one and unacceptable to another. And some patients are looking for pain relief, and others are looking for functional improvement, and others are looking for both, and would find anything less than that unacceptable. And therein lies the challenge of using PROs in isolation. I think they're really most beneficial when used as a piece of information with everything else we collect in terms of patient care. But again, I think it was an excellent study. Thank you.
Yeah, thank you. I agree with all those points. I think these are all established in population-based studies. So it's hard to go from that to the individual. Certainly you can consider it, but it's not the be-all end-all within individual clinical patient care. But I think using these in the context of other population-based studies is probably the right application for them, at least as they are currently.
Okay, thanks, James. Unless there are other pressing comments, I think we should move on in the interest of time. Leslie, are you up next?
Yeah, I'm going to go ahead and
Fantastic.
share. Okay, so this morning I'm going to be talking about, does proportional distalization and medialization affect outcomes in Grammont-style reverse total shoulder arthroplasty? So our hypothesis was that while our previous work failed to find a relationship between component position and patient outcomes, if we contextualize the center of rotation and amount of distalization with the patient's starting muscle length, a relationship would be found. Essentially, that 2 centimeters of distalization or medialization matters differently to a patient that's 5 feet tall as compared to a patient that's 6'5" tall. So a brief introduction. Reverse total shoulder arthroplasty is a surgery that generally has excellent outcomes. The ideal component positioning and component design remains controversial or elusive, and there's little literature regarding patient-specific positioning of components. Briefly, some concepts in component positioning in reverse. There's essentially this idea that there's no free lunch, and while a more lateralized component may decrease notching, confer increased stability, it's at the expense of increased joint reactive forces, increased deltoid forces. So while you may get improved external rotation, it may be at the expense of forward elevation and abduction. Similarly, increased distalization can confer stability, can increase deltoid tensioning, but it may put stretch on the axillary nerve and increase the risk of acromial stress fractures. The Grammont-style reverse, which is the style that we used in this study, is a medialized center of rotation that distalizes the humerus. A couple of studies that just continue to show the controversy, and that you can find a study to support essentially whatever you're doing, similar to a lot of things in the orthopedic literature. The first review found no difference in outcomes between medialized and lateralized center of rotation, while the second study found that lateralized components was the only variable associated with poor forward elevation. So the background for this study, which essentially combined 2 previous studies, the first study being Dr. Tajin's, which retrospectively reviewed 230 of his reverses, again, using that Grammont-style of a component. And they looked at radiographic parameters, patient-specific parameters, patient-reported outcomes, complications, and reoperation rates, and somewhat surprisingly found no association between the radiographic measures and patient outcomes. Another study done by Dr. Chalmers looked at preoperative CT scans and measured deltoid and infraspinatus length, and then also recorded patient-specific features, and then used a linear regression to generate formula to predict muscle length solely based on height of the patient. And these formula were pretty accurate, within 2 centimeters of the muscle length in about 90% of patients. So our study, we returned to the patients from Dr. Tajin's paper, and we collected patient heights, and then we used the formula generated by Dr. Chalmers' study to calculate the predicted muscle lengths of the deltoid and infraspinatus for these patients. We used distalization was measured using the acromial greater tuberosity distance, and then the amount of medialization was measured looking at the center of rotation and the line of pull of the deltoid. So this seems a little bit mathy, but it's actually a pretty simple concept. We use the preoperative and postoperative radiographic measures to calculate the change in deltoid length and the change in infraspinatus length. And then we contextualize this for the patients by dividing it by their preoperative predicted muscle length to essentially calculate the percent change for that specific patient in their muscle length. These new variables were rerun in the similar analyses from Dr. Tashin's paper, looking at outcomes and complication rates. Moving on to our results, we found that percent distalized range from 3 to 38% of the patients calculated preoperative deltoid length and 4 to 45% of their calculated infraspinatus length. The mean distalization was about 20% of preoperative deltoid length, and the mean medialization was about 18% of their infraspinatus length. We found no difference in the percent change of muscle length by sex. What about the extremes? Were these different in the tallest and shortest 1% of patients? We found that the mean within the tall patients and the mean within the short patients fell squarely within one standard deviation of the overall group. So again, there was no difference here, no outliers based on the outliers in height for the patients. We did not find a relationship between outcomes and the percent change in the muscle length, or in a relationship between reoperation and the percent change in the muscle length. So some conclusions. Our hypothesis was not found to be accurate. While the Grammont-style reverse is a forgiving implant with generally excellent outcomes, we did not find a relationship when we contextualize the component positioning for the patient's height. All of these surgeries were tensioned essentially by feeling the shock, feeling the tension on the muscles clinically in the operating room. And this study suggests that this is reliable and can reproducibly predict, or can reproducibly produce a clinically acceptable range of muscle change for the patients. This also shows that patients tolerate a range of muscle tensions. The fact that patients whose muscle was changed about 5% to close to 50% didn't find a relationship with their outcomes or reoperation suggests that this is well tolerated. This study does not help define what the ideal positioning of components is. And I think that this is sort of an elusive goal for some of the reasons mentioned initially, that there's no free lunch. You're robbing Peter to pay Paul. So it's sort of finding a happy medium. Some limitations: this is a single surgeon, single institution study, may not be generalizable. There were some patients who were lost to follow-up. And then the change in muscle length that we calculated using two-dimensional measures. Well, of course, the muscle volume was not calculated. A future study could look at objective strength change based on percent change in muscle length, which we were not able to capture with this study. So I just want to thank you to the department for the support and open up to any questions.
Yeah, thanks, Leslie. That was a great presentation. I think all of us were. I still am somewhat surprised by this finding that basically it doesn't seem to matter where you position the implant to some degree, as long as it feels good in the operating room. I think that we're still kind of understanding the way that reverse total shoulder arthroplasty works, and it may or may not be true that this directly equates into range of motion, and we'll have to do future studies to understand that we're working on. But certainly range of motion should correlate with outcomes, and the outcomes here do not appear to be associated with how much you tension the implant in terms of medialization, lateralization, distalization, which very much runs contrary to what everyone is saying on the podium right now. So I'd be curious to hear everyone else's thoughts, but I thought it was a nice presentation.
Thanks.
Agreed, Peter, that I think this is a great study, and I think that we're only really starting to understand why people do well or don't do well with a reverse, and a lot of the understanding is based upon very rudimentary conflict of where implants will touch bone, and then just trying to maximize gross range of motion in a conflict model instead of actually what occurs in a patient. And so at least this is a first step to be able to actually move towards more of a patient specific decision about what to do. The one thing that Leslie, I think, points out well is that it doesn't necessarily mean that at the high extremes of that the outcomes can be influenced by this, so that if we lengthen the arm 3 times what we normally should be doing, there could be potentially negative impact in that. So for whatever it's worth, there's an acceptable range that we're seeing that probably if you fall within this, at least from a functional outcome standpoint, patients are doing okay. So good work.
Nice study, Leslie. Just a quick question. You measured pre versus post-op deltoid length. Did you have any means by which to normalize to what a nominal resting length would have been? Because a lot of these patients could be superiorly migrated, which would essentially shorten their pre-op length, and then overcorrect as a relative percentage after the procedure.
The formula that we used from Dr. Chalmers' patient, I think, attempted to correct for that. These were the patients used in his study were preoperative reverse patients, so they certainly would have seen some shortening already. But I think using a patient with a normal shoulder isn't necessarily representative of where their muscle length is at that time before surgery. So I think it's actually appropriate to use that, where they're starting pre-op as opposed to where they were at, age 25.
Right. Yeah. So just as a follow-up, I mean, were there any concerns about, a lot of these patients are presenting with a pathology that's limiting their shoulder motion. So concerns of atrophy or sort of under or disuse of the deltoid, do you think that could play a role?
Yeah, I think that could play a role. That's not something we necessarily were able to capture with this study. I think you would have to, it would be more difficult with this type of retrospective. You would probably need to be doing more measuring preoperative objective strength pre and post operatively, which I think is definitely an area of future study.
Okay. If there are any other questions, now's a good time. Otherwise, we'll progress on to, is it going to be Mick or Nathan next? It's like Nathan.
Thank you. I'll be presenting this work regarding PROMIS physical function and pain interference as predictors of adverse outcomes after intermittent spinal fusion. As a background, so preoperative risk stratification is really essential for making informed decisions, for accurate patient counseling, and for evaluating the outcomes of our treatments. The limitations of the common risk stratification tools that we use, including Charlson Comorbidity Index, the Frailty Index, the Anesthesiologist Society, American classification schemes, are that they're often derived from documentation of patient medical comorbidities, which brings with it an inherent limitation of documentation errors, and also that these risk stratification tools really tell us very little about a patient's functional status. They just happen to be available in large retrospective databases. We could say that for any group of patients of a similar age, the patient on the left is not equal to the patient on the right, although they may have the same patient age and comorbidities and risk factors that we readily identify in these retrospective studies. So the question really becomes, in the age of machine learning and big data that we have, is the risk of a patient having an adverse outcome or the likelihood of a good outcome really equal to the sum of patient medical comorbidities, which is what we are often using now for risk stratification? And the answer is only in retrospective database research is that the case. These two images, which I believe may have been presented previously, show briefly the variables that are included on the left of calculating a Charlson Comorbidity Index, which is truly just the presence of these medical comorbidities. which is similar to on the right, the modified frailty index, and then using these variables to transform them into some ratio or number based on how many of the underlying conditions are present. So one of the measures that we routinely collect in all the orthopedic specialties here at the University of Utah is the patient-reported outcome measurement information system scores, including the physical function and pain interference computerized adaptive test. These measures have been widely validated. They're excellent unidimensional measures of physical health or the limitation due to pain. They have excellent psychometric properties with minimal floor to ceiling effects, and they give us true scale data to do research with if so inclined. These results can be transformed into T-scores, which are derived from the US population, where a mean score for these metrics is 50 and a standard deviation would be 10 points. Question, of course, is how does this help us to stratify patients? Again, we have these two patients who may look similar based on their comorbidities, but can we use something, an objective measure like a PROMIS, to better stratify and counsel these patients? One of the earliest lessons that I learned in spine surgery is that if I have a question about spine surgery, chances are the answer's already been published by Dr. Brodkey. So sure enough, there's an article out there with Dr. Brodkey as a senior author, and to kind of contextualize how these scores can work in a long and busy image. So looking here at our population mean, so a PROMIS score of 50 plus or minus 2, these patients can walk more than a mile with no difficulty. If we go 2 standard deviations below to a PROMIS physical function score of 30, kind of a conceptual anchor that this patient is unable to walk at normal speed. Likewise, with the pain interference tool, we can take a population mean of 50 and conceptualize that as pain really doesn't interfere with the patient's enjoyment of life or interfere only a little bit. Whereas if you go up 2 standard deviations in the pain interference metric, pain interferes with work around the home very much or quite a bit. So remembering that these 30 for physical function and 70 for pain interference is kind of that 2 standard deviation number that we often look at, and this will become relevant later. So our research question is, are PROMIS physical function or pain interference scores independent predictors of adverse outcomes after spinal fusion? So we did a retrospective cohort study based on our spine registry, utilizing the CPT codes below to identify patients undergoing lumbar arthrodesis. We excluded patients with a dirty or contaminated wound class and also excluded trauma patients. And then all these patients had a preoperative, postoperative PROMIS physical function and pain interference score. We also calculated their Charlson comorbidity index, their modified frailty index by the usual method using their documented comorbidities. The PROMIS scores included the preoperative one, which was the closest score within 90 days prior to surgery. And then all these patients had a postoperative score up to 12 months. We then looked at the postoperative adverse outcomes by abstracting the chart, initially by an automated query using diagnostic codes, and secondarily by manual chart review. All the patients who had the outcomes of interest, such as ED visits, readmissions, unplanned reoperations, wound healing complications, were audited by manual chart review to confirm the findings. Data management, again, our primary outcomes were unplanned reoperations, wound healing complications, and unplanned readmission. We then assessed the relationship between clinical outcomes and risk stratification measures, looking just at a simple correlation between the PROMIS scores and the Charlson Comorbidity Index, which is one of the most widely published risk stratification tools. And then we also used regression to look at risk stratification for these adverse outcomes based on the different stratification tools. Finally, our what I think is the most important analysis was to use a random forest model to assess risk stratification. And the crux of this random forest model is that it can use a kind of a machine learning algorithm to identify the variables with the greatest importance in predicting your outcome of interest. So for results, we had nearly 1,800 unique patients. They were approximately 62 years old and roughly equally distributed among men and women. The preoperative Charlson Comorbidity Index was approximately 2, and the preoperative physical function score, which we looked at those anchors previously, was 33. So our patients were approximately 2 standard deviations below the mean in terms of their physical function, and approximately 2 standard deviations above the mean in terms of their preoperative pain interference. The relationship between these PROMIS physical function and pain interference measures and the Charlson Comorbidity Index was a weak one. The physical function was significantly, although very weakly, correlated to Charlson Comorbidity Index, whereas the pain interference was not statistically nor relevantly related to Charlson Comorbidity Index by correlation. And those are adjusted for all the other factors that we included. So there was 167 patients that had unplanned readmission or trips to the emergency department. 63 patients, or 3.6%, had an unplanned reoperation, and 36 patients, or 2.1%, had a healing complication. A busy slide, I'll highlight what is relevant here. So this is broken out by patient BMI, excuse me, and looking at patients who are underweight, normal weight, overweight, and obese, and then our outcomes of interest. So down here, patients who had an antibiotic, and that's kind of our shorthand for patients with a wound healing complication, including wound dehiscence, surgical site infection, and that's regardless of whether they went to the operating room or not. So the rate of wound healing complication was 7.7% in underweight, which is consistent with some of the newer literature that would suggest these patients have more risk than even overweight or obese patients, although obese was higher than normal weight. Readmission to the hospital, likewise, was higher in the obese compared to normal, but highest in underweight. And a similar trend was also seen in the return to the operating room, where 84.6% for underweight, and then 91% normal. 8.6% in normal, 8.3% overweight, and 10.9% here in the obese. So the random forest model, and again, just to kind of the take-home point here, is that this helps predict what is the strongest predictor, the most important predicting variable when you model for these outcomes. So when we look at first the use of antibiotics, which is our wound healing complication. So this Gini index, the way this works is that the number with the highest value is equivalent with the risk stratification tool or predictor variable with the greatest importance. So for all 3 of these outcomes, wound healing complication, hospital readmission, and return to OR, BMI actually had the greatest importance. The next greatest importance for all 3 outcomes was the PROMIS physical function score. For use of antibiotics, it was very close behind BMI, as was hospital readmission, and unplanned return to the operating room. It was also the second most important predictive variable. The third most important predictive variable for all 3 outcomes was the PROMIS pain interference score. Notably, our traditional risk stratification tools, including the Charlson Comorbidity Index, age, and smoking status, trailed markedly behind those top 3 predictive variables in the importance of predicting our adverse outcomes. This is kind of a big step forward, because random forest modeling is a more flexible modeling technique that isn't constrained by the usual assumptions of linear or even logistic regression. So in conclusion, BMI, PROMIS physical function, and pain interference were the most important predictors of all 3 adverse outcomes in this study, whereas the Charlson Comorbidity Index, smoking status, and age were far less important for predicting the outcomes that we're trying to avoid in these patients. So physical function and pain interference, although traditionally our outcome measures, are promising tools to better provide really personalized patient counseling regarding the potential risks and the likelihood of benefits following surgery. So moving forward, where can this research go? So this is part of kind of a bigger aim that I think of, that I just kind of colloquially call enhanced risk stratification. So one, we need to stop relying on poor adjunct measures of how sick a patient is, which is really what we're doing if we just tabulate how many comorbidities they have and then translate that number into a risk factor. We need to utilize better objective markers of a patient's status. So for functional status, which is really what frailty is trying to assess, the PROMIS physical function is a very good subjective, but gives us kind of scale information on that patient's functional ability. Psychosocial status, which has been shown multiple times to influence the outcomes after a surgery, the PROMIS pain interference appears to have pretty good predictive value for this. Physiologically, instead of measuring, say, albumin, we should be measuring things like actual inflammation markers like CRP, interleukins, or nitrogen balance. And nutrition, we should be using validated nutrition screening and body composition measures. This is all enhanced further by combining these outcomes with advanced analysis using artificial intelligence or machine learning. And what this gives us is the opportunity to provide targeted risk mitigation for our patients. If this sounds like it's pie in the sky, here's a paper from 2019 from the International Spine Study Group, where they took this massive number of variables and they used artificial intelligence to use what they call what's clustering. So what they did is they took all these outcomes and they clustered patients into groups where they seemed to be more similar than patients in these other groups. And once you develop this kind of nodal network or cluster, you can then take patients that you're counseling real time, and the AI or machine learning will identify which patient are they most similar to. And this allows you to have some predictive ability on where they fit in terms of risk for adverse events, or where they fit in terms of the likelihood of a positive outcome. Based on that, you can start recommending targeted risk mitigation measures to better optimize their outcomes. I think this is really kind of the next iteration of big data and personalization of care for our patients. With that, I'd like to thank everyone, especially my mentors on the spine surgery team, and would be happy to answer any questions.
That was a great talk. This is Charlie Saltzman. I didn't pick up on this, and you probably, and this is a fascinating field, and I don't understand it, to be completely honest and open. I really don't understand the background to artificial machine learning and how this all fits together. But my simple orthopedic question is, what was the direction of risk impact of the, I don't know if you mentioned this, of the PROMIS physical function and pain interference skills? Lower scores cause greater risk, or higher scores are associated with greater risk? Not cause, but are associated.
Yeah, thanks, Dr. Saltzman. Important differentiation. So patients with higher physical function and lower pain interference tended to have a lower likelihood of adverse outcomes, as we'd kind of expect. Whereas so patients with lower physical function and higher pain interference were more likely to have less improvement in their PROs post-op and more likely to have an adverse outcome in their post-operative course.
Does it surprise you? Does any of this surprise you? And how will this affect, say that's the only information you know about how to pick patients in clinic? How would you decide who to operate on?
It doesn't surprise me. And I think that's kind of how this research question evolved, is talking about all the risk stratification measures and saying, here we've got this number that we think is really good for measuring a patient's physical function or their ability to get around and be independent. And then we've seen in multiple ways how pain catastrophizing or pain interference has deleterious effects on outcomes after the same intervention. I think in terms of going forward, and what I've seen done is, when patients check in and use the iPad or the kiosk and they're entering their PROs, when counseling a patient about, here's the condition, this is the natural history, here are the treatment options, these are the expectations that I would set for you, being able to pull up this information and say, look, you have, moderate or mild stenosis in your spine for our, the spine purposes. And you have your pain interference score is 90, which is essentially greater than 99% of the population. The likelihood that you're going to have a really, really good outcome based on this information is very poor. Or vice versa, if this same patient had, we see these patients who have extraordinarily severe stenosis or arthritis of the knee or ankle and are really getting by quite well, but are extremely limited because of their symptom. You say, based on all this information, based on the amount of pain and disability you have from this particular condition, we can predict that you have, 80% likelihood of having a very good improvement in these scores post-operatively based on all this information. And if there's, you start adding in these other pieces and saying that, you have all these markers of very bad chronic inflammation and poor nutrition and bad coping, you say, one, before this surgery that we're not sure is going to be a home run, I'd like you to see psych nursing and work on pain coping skills. And because that's going to be a big part of your outcome after surgery, we're going to send you to nutrition or endocrinology and optimize all these other factors to really stack the deck in our favor to have the best outcome that we can post-operatively for you.
Thanks, that's great. And just to follow up, one more question. Could you conceive of a ratio of pain interference versus the difference, perhaps, between pain interference score and normal, and physical function score and normal for the population, age matched, that would then stratify patients in a way that would be meaningful for clinical care?
That's a great question. So the way that we modeled this information, because you could imagine a scenario that a patient is extremely debilitated due to their condition, and either that patient has very high or very low pain interference. It's hard to tease out some of the other things, like is it from deconditioning or just because they don't move because of their pain. So we actually ran the modeling with a separate model that looked at just pain interference and all the other factors, another one that looked at just pain or physical function and all the other factors, and then finally with both, and let the random forest modeling choose which was more important. And it turns out they were essentially the same. So there's likely a lot of collinearity, or I shouldn't say collinearity. There's probably some interplay between physical function and pain interference, especially when it's, orthopedic conditions where maybe their limitation is due to pain and dysfunction from whatever the condition is they're showing up in our clinic for. But I do think that's kind of the end goal, is how do we tease that out better amongst all their comorbidities and their condition and their psychosocial makeup to better address one or multiple of those factors.
I was going to add one more question. I think great talk. And this is a follow-up to Charlie's line of questioning. And I'm going to maybe even preface it by giving what I think is the answer in the interest of time, which is it's complex and there are so many variables. But the very flip side of the presentation of the risk for readmission or complications is that there is a trend in even publications suggesting that we should use these PROMIS scores, both PF-CAT and pain interference, to suggest patients that should be eligible to undergo surgery. In other words, if they have a physical function score that is higher and a pain interference score that is lower, it suggests that they're not that bad off and they ought to not receive treatment from us. And so this is absolutely flying in the face of that, because what you're saying is it's a patient that has a higher score and a lower pain interference that's likely to have a better outcome. But so I guess my point is, I think it really illustrates what you found here is that this is more complex than just looking at a score and telling someone their ability to get better or how well they're going to do. There's a lot of factors that go into it, which is why we are doctors and not just looking at a computer. Does that make sense?
Yeah, and it totally does. And I totally agree. And I think that's kind of one of the reasons why I've avoided the kind of, there's always an interest in saying, this above this number is good and below this number is bad. Then it kind of gets oversimplified and people will, if your score is above this, we'll do surgery. If it isn't, we can't do surgery, whether it's like a BMI of 40 for, a total hip arthroplasty at the VA. There's just more to it than that. Trying to avoid early on publishing a number that gets really kind of latched onto in literature and maybe isn't the message that is trying to be conveyed.
All good comments and questions. Thanks a lot, Nathan. I think it's probably a good time to move on to our final presentation today in the interest of time.
All right, good morning. My name is Mick Kelly. I'm one of the Joint Replacement Fellows. And the title of my research project is Oral Antibiotics, Increase Bacterial Resistance in Patients Who Failed Two-Stage Exchange for Periprosthetic Joint Infection. So as we all know, periprosthetic joint infection remains a devastating complication in the field of arthroplasty. Oral antibiotics at the time of stage 2 reimplantation may reduce subsequent PJI. So there was a recent multi-center randomized controlled trial that randomized a certain percentage of the patients to receiving 3 months of culture-directed oral antibiotics at the time of stage 2 compared to the control group that did not receive any antibiotics. And their initial report was quite convincing that the antibiotics was helpful. So this led to a widespread clinical change, as well as a change in the protocol at our institution around 2017. The most recent update from this report is shown on the slide. So with 142 patients followed for an average of 3.3 years, the patients that received 3 months of oral antibiotics had a 12.5% rate of subsequent PJI compared to 28.6% in the control group. So while this initially seems beneficial for arthroplasty surgeons and patients alike, the authors failed to look at some of the potential adverse effects, such as increasing bacterial resistance in any subsequent PJI, which was the motivation for our study. So the two questions in particular that we wanted to address was, number one, do oral antibiotics at the time of stage 2 reimplantation increase the rate of antibiotic resistance in any subsequent infection? And then also, do oral antibiotics reduce the overall rate of recurrent PJI in our patient population? Our hypothesis was that providing oral antibiotics would increase bacterial resistance, but would decrease the overall rate of PJI. So we performed a retrospective review of the patients at this institution who underwent a 2-stage exchange for PJI between 2014 and 2019. We used the cutoff at the end of the calendar year of 2019 to ensure that we had at least 1 year of follow-up for the surgical patients. This flowchart at the bottom shows the typical pathway for one of the patients in the study. So initially they undergo an index total knee or total hip, which is then complicated by a periprosthetic joint infection. And then they undergo a stage 1, which includes explantation of their components with placement of an antibiotic spacer, followed by a minimum 6 weeks of IV antibiotics, followed by a stage 2 reimplantation. And then at this point, some of those patients received no oral antibiotics, while others received a prolonged course of oral antibiotics. And that was that comprised the patient cohort for our study. So first of all, we used a minimum of 2 weeks of antibiotics to include people in the antibiotic group. Most of them received 3 months, which was similar to the randomized controlled trial. And the other thing is the indication for receiving antibiotics at the time of stage 2 prior to the results of the randomized controlled trial was based on surgeon discretion. And then after it became more routine. So when we looked at our data, 2014 to 2016 was about 25% of the patients received antibiotics. In 2017, the year that the results came out, there was 65% rate of antibiotics prescribed. And then since then, it's been about 99% of the patients. We classified a positive culture into one of 3 groups. A resistant organism had intermediate or high resistance to the prescribed oral antibiotic. For polymicrobial infections, if any one of the organisms was resistant, we included it in this group. And then we also compared the resistance to doxycycline in patients who did not receive oral antibiotics, since 86% of our patients received doxycycline as the antibiotic. A sensitive organism was sensitive in the susceptibility testing, and then we classified the culture as unknown if there was no susceptibility data in the microbiology report. A negative culture included a single colony growth on one culture, as well as broth-only growth of one culture. So we did not find any major differences in the demographics between the two groups. As you would expect, this was an older, sicker patient population. Average BMI was about 33. There was 30% rate of diabetes, 20% rate of RA and chronic kidney disease, and we had a pretty even split between hip and knee patients. So this shows a flow chart of all the patients in the study. We had 211 patients in total that underwent a two-stage exchange. This may not seem like that high of a number, but for a study like this with a PJI patient population, this is actually a very large study. The initial results from the multi-center randomized control trial only had 105 patients, and their most recent follow-up had 142 patients. So this actually represents quite a large study. About a quarter of our patients did not receive antibiotics, whereas the 3/4 of them did receive antibiotics. And we had 11 patients in the group that did not receive antibiotics, eventually were diagnosed with PJI, compared to 24 in the group that received antibiotics. So looking at these a little bit further, in terms of making a diagnosis of PJI, it's not always a straightforward diagnosis. So ideally, we use the MSI as criteria, and 29 out of the 35 cases met criteria for PJI based on the MSI as criteria. We also had 6 patients that did not meet the criteria, but had various characteristics and were treated as though they had a periprosthetic joint infection, and therefore we categorized them as a probable PJI and included them in the group with the diagnosis of PJI. So when we look at the rate of resistant organisms, in the group of patients that did not receive any oral antibiotics at stage 2, we had 0 patients that developed a PJI with a resistant organism. This was in comparison to the group that received prolonged antibiotics. 16 out of the 24 patients that were diagnosed with PJI had a resistant organism. So I think this slide is really the take-home message from this project, which shows a pretty significant difference between the two groups. When we look at the microbiology one step further, there's a few interesting things to point out. So on the left is a pie chart of the patients that did not receive any antibiotics, and you can see it's mostly composed of sensitive organisms. On the right, the portion in red represents resistant organisms. And we also had 4 patients that had culture negative infections that we did not see in the no antibiotic group. Now, all of these organisms were different than their initial PJI, with the exception of 1 patient in each group. And this is actually aligns well with the data from the multi-center randomized control trial that showed that the majority of the PJI was with a different organism. One more thing to point out here is we had 9 cases of resistant staph epi. Staph epi is one of the most common bugs that we see. And when we look at the antibiogram at the hospital, over 85% of the staph epi in the hospital is sensitive to doxycycline. But as a larger group of coag-negative staph, we know that most of those are actually resistant to beta-lactams, clindamycin, and TMP sulfa. So what this means is that if you do develop an infection with staph epi, the 2 oral agents that are most commonly used, and the only 2 that are really available right now, are doxycycline and linezolid. Linezolid has issues with the safety profile, which makes doxycycline the drug of choice to treat these patients with long-term oral suppression. So the fact that we're finding resistant cases of staph epi makes it very challenging to treat these patients with long-term oral antibiotics. Looking at our overall rate of recurrent PJI, if we just take a step back and look at the rate overall, it's actually quite low, and there's a lot of different numbers thrown around in the literature, but I think our success rate at this institution is quite good overall. Now, when we stratify the patients based on no oral antibiotics compared to receiving prolonged course of oral antibiotics, the rate of PJI was 21% compared to 15%, which showed a trend towards a reduction, but this was not statistically significant. I would point out that this study was not set up to show significance here or to really study this in particular. And likely this effect was underestimated because you would assume that the patients prior to 2017, the high-risk patients were more likely to receive an antibiotic. So in summary, prolonged oral antibiotics at the time of stage 2 reimplantation increase drug resistance to that antibiotic and any subsequent PJI, but show a trend towards a decreased rate of PJI. And therefore, we recommend further research to refine these antimicrobial protocols. Just want to thank everyone here for a fantastic fellowship year, and in particular, Dr. Gilliland, Brenna, and Dr. Certain, shown in the bottom right, who helped out a lot with this project. And it's pretty unique to have a ID clinic and a joints clinic in the same hallway, but I think it's awesome for patient care, and it really sets up a great collaboration for projects like this as well. So I'd be happy to answer any questions if we have a few minutes.
Thanks, Mick. Our time is a little bit limited, but I think we can squeeze in a couple questions if we need to.
Hey, Mick, this is Lucas Anderson. Really great study. I think it rounds out our understanding of the pros and cons of antibiotics. What are you going to do in your practice going forward? Are you going to be a good antibiotics steward, or you care about the individual patient, or how do you balance that out?
Yeah, I think we definitely need to study it more to kind of learn more about the different risk factors for resistance, as well as different antibiotic protocols. I think a lot of those other studies, like some of Meneghini's papers, they're using different antibiotics, and maybe it's more of a tetracycline issue. I think our results are pretty convincing. So to answer your question, I would say as of right now, I would still give oral antibiotics at the time of stage 2, because I think the data is convincing for reducing the overall rate of PJI, but I will be more hesitant to give it for high-risk primary patients.
I think if you have an ID clinic in your hallway, you're at a greater risk of taking care of infection patients.
I agree, and I hope that I don't have one, but yeah.
The one challenge that you have is I actually don't even know what our protocol is. It still seems a little bit haphazard, even in my own practice, to decide who does and doesn't get it. And even if I thought maybe they were going to get it, maybe they didn't. And it's interesting how well you were able to mine the data, because I'm not exactly sure what the protocol is, despite the fact that I think there's a definite trend to increase utilization since Meneghini's papers, since, as you mentioned, 2017 timeframe.
Yeah, are you talking about difficult primaries or stage 2, Dr. Pell?
Yes.
Both?
Both, yeah.
Yeah, I think.
Yeah, I mean,
go ahead.
Well, no, I was just going to say, just as a, you brought this up recently, so that everyone can hear, we just got this accepted as an MSIS podium, but in that same meeting coming up, there's a paper being presented saying in high-risk primaries that are getting extended oral antibiotics for these high-risk players, we did not see, or this group that's going to present did not see a development of antibiotic resistance in those people. So you wonder, is this something about the duration, right? We're giving these 3 months as opposed to these high-risk primaries that may get a week of antibiotics. And is it something about the patient profile and their immune system being assaulted by so many things that, these bugs are able to develop these resistance patterns? So there's so much more to this that we don't understand. And I think my take home from this is we need to be careful. And I really want to sit down with Laura and with you as we think about this in the future and come up with what are the best antibiotics to be considering, and is doxycycline our choice? Because clearly developing resistance to doxycycline becomes somewhat dangerous for this patient population as we run out of options. So great study. I think it leads to lots of great questions and further research, and and helps put us on the map in this arena. And I think it challenges paradigms that are developing that really are getting somewhat dangerous in our field, where everybody's just saying, I'm going to give antibiotics to everybody. And that's what Meneghini's study is saying. Forget high risk, everybody should get it. And I worry about that.
Okay, any final comments or thoughts here before we call it a morning?
It's a great set of presentations, and I really like the format, and I wanted to thank everybody. It was excellent morning. Thank you.
Okay, thanks everybody. Take care.